Hey guys, this is Miss Buck. This is the third and final part to our musculoskeletal disorders for this class. So, without further ado, we're going to get started. This section will be covering DVTs. All right, so DVTs are just, for simpler terms, blood clots that occur in a large vein. DVTs are typically found in the leg or the pelvis, but they can be found, I have seen them in people's arms as well. So the prevalence of DVTs is about 1 per 1,000 people a year. And sometimes DVTs detach from the site where they form and they become mobile in the bloodstream. So, if that happens, if we have a circulating clot that moves through the heart to the lungs, it can block an artery that ultimately supplies blood to the lungs. And then that's when we call it a pulmonary embolism, or a PE for short. So it's estimated that about 350,000 to 900,000 Americans each year suffer from DVTs and PEs, and the disease process that includes DVT and or PEs is called venous thromboembolism. So VTE. In hospitals, you will see it termed VTE prophylaxis, and I'm saying V as in violin, VTE prophylaxis, and that is basically either heparin or TED hoses or SCDs or Lovenox, some type of therapy to help prevent VTEs from occurring. So, at least 100,000 deaths may be directly or indirectly related to these diseases. And it's also I just want to throw in there, about 10 to 30% of people who survive the first occurrence of VTEs develop another VTE within 5 years. So, risk factors include increasing patient age, active cancer that can be with or without chemotherapy, varicose veins, any prior venous thrombosis, pregnancy, postpartum period, oral contraceptives. A lot of people forget about birth control. Birth control does put you at a risk for DVTs, a higher risk. Hormone therapy, and then surgery, trauma, hospitalizations, nursing home confinements, anything that results in immobility is also going to make you an increased risk. And we also can include procedures such as central venous catheters, so CVLs, your central lines, placements of those, and then transvenous pacemaker insertions also increase the risk. So, talking about the patho, so we use something called Virchow's triad to assess and describe the risk factors for patients for DVTs. So, the three big things for Virchow's triad are going to be decreased flow rate of blood, so stasis, damage to the blood vessel wall, the endothelial injury, and then an increased tendency to clot, so hypercoagulability. So, like I said, Virchow's triad describes the factors implicated really in the formation of a venous thrombosis. So, the next slide, y'all, I'm eventually going to stop doing that, but Lord Jesus. Okay, so this slide shows the different, the three things that we look at. So, that hypercoagulable state, vascular wall injury, and then circulatory stasis. So when we think of like AFib, for example, that's a big one. The atria are just quivering essentially, right? So we've got blood that gets static and just sits in those, and if they clot and that clot breaks off, then we can have really big problems. So this is just a little diagram to help you. I would probably really look at this and have this kind of memorized to a degree. But this is really important to know just in everyday practice as well. All right. Dadgummit. Okay, so these are just the deep veins of the leg. So you can see here that we have normal blood flow. This is that one-way valve that we have in our leg that prevents backflow. We have restricted blood flow. So we've got a little clot forming here. And so we've got a little bit of a restriction going on. And then this is going to be an embolus that is broken off from this clot and is now traveling in our circulatory system. So that's no bueno. All right, so some clinical manifestations. So people with DVTs may or may not have symptoms. The clots can cause partial or complete blockages of circulation in the vein, so that can lead to pain, swelling, tenderness, discoloration, or redness and warmth in the affected area. The clinical manifestations really vary depending on the size, the location, the degree of occlusion, and adequacy of that collateral circulation. So, table 31.13 in your book really kind of does a really good job of describing the common clinical manifestations that we see with calf, femoral, iliofemoral, and upper extremity thrombosis. So we also look for the presence of Homan sign. So that is calf pain that is elicited on dorsiflexion of the foot. And it may indicate the presence of a DVT, but its routine use in evaluation really is not recommended because it frequently is misinterpreted and just really isn't a reliable predictor. All right, so for medical management and for diagnosis, the two big things that we're going to use are D-dimers and compression ultrasonography. So these really have proven to be the most accurate, safe, and truly effective diagnostic tools for DVTs. So, the evaluation of a patient with a suspected DVT begins with an assessment of a set of clinical prediction rules, pre risk probability, things like that for a DVT. We're assessing how high of a risk they are. We use what's called a Wells score for that categorizes patients as high, moderate, or low probability. And then this is based on the presence of the clinical features that's commonly associated with those DVTs and identification of an alternative diagnosis. First step in treatment truly is prevention. That's why I was talking about VTE prophylaxis earlier. You're going to see those patients post-op, anybody in a hospital. These things are very, very preventable when prevention is done early on. So we're going to do everything we can to prevent this from happening. In low-risk patients, truly early ambulation is really all that's necessary, but venous VTE prophylaxis is indicated at risk hospitalized populations. So, like I said, those surgery patients, trauma patients, people like that. In patients with a low bleeding risk, pharmacological prevention is recommended. So the preferred meds include those low molecular weight heparins or unfractionated heparin, or patients with heparin-induced or in patients with heparin-induced thrombocytopenia, HIT. There is another med, fondaparinux, that can be used, and in patients with a higher risk of bleeding, mechanical VTE prophylaxis is indicated. So that's going to include those compression stockings, those foot pumps, those active external devices that we see, SCDs, things like that. And the benefits of these really include their effectiveness, ease of application, and then the safety, especially in respect to bleeding. And then intermittent compression devices apply external pressure to the limb, which promotes blood supply and reduces that venous stasis. So it's basically just squeezing intermittently, kind of contracting those muscles, just like it would if you were ambulating. Medication therapy typically consists of those anticoagulation with unfractionated heparin or low molecular weight heparins, followed by long-term oral anticoags with warfarin. So these conventional anticoag therapies really are widely used, but they do have their limitations, just like with everything or anything. So they require regular monitoring to make sure that We maintain safe levels. Newer oral anticoags that include direct thrombin inhibitors like dabigatran and direct factor XA inhibitors like apixaban is the most common one that I can think of for that, or it's Eliquis. These have been developed to overcome some of the limitations of the conventional anticoag therapy, and they've really been evaluated for safety and I never say this word right. Efficacy. There we go. Efficacy. I'm so sorry, guys. In large randomized clinical trials. So, um, they're a little bit safer and have taken a little bit out of having to monitor as frequently of lab levels. So I'm going to hit real quick on TPA. So thrombolytic therapy like TPA really isn't routinely administered in patients with DVTs. And it's because these thrombolytic agents really have a more rapid and complete thrombolysis, and that's really potentially preventing PE and decreasing the incidence of recurring DVT, but it's not associated with decreased mortality, and it is associated with increased risks for bleeding. So, because of this, thrombolytics are only used under certain circumstances, and they include patients really who have failed conventional therapy with a clot that's been present for less than 14 days and have a low bleeding risk. Further assessment is really made based on individual patient circumstances and the size and location of the clot and pre-existing conditions. All right. So medication therapy typically consists of anticoag, like I said, with that unfractionated heparin or low molecular weight. So this slide really is just breaking those medications down that we can use, and it's showing what the normal lab ranges are. So for warfarin, we're going to be checking a PT, and normal is 10 to 13, but therapeutic range for people who are on it is 1.5 to 2 times that number for the normal. We can also check an INR, and its normal is 0.9 to 1.1. And an INR of 2 to 3 is standard really just for therapy for people who are currently taking this. And then 3 to 4.5 is what we want to see for the high dose therapy. The antidote for warfarin is vitamin K. It's really important to know. You guys may have learned some of this already in PathoPharm, but we're hitting it here again because it's really important. So for direct factor XA inhibitors, that's going to be Pradaxa and Xarelto. There really isn't any blood testing that's required. But for warfarin therapy, and heparin's not on here, but we can, and it's very frequently used in the hospital. I've seen APTTs and anti-10As used on heparin therapy for lab results. And those kind of vary depending on your facility, but your book will give you a good reference range to use, just because both hospitals here in town, one uses an APTT or APTT, and the other uses anti-10A, and those can vary in ranges what the hospital finds acceptable a little bit. So surgical management really is rarely utilized to remove DVTs unless there's just a massive occlusion that we can't get to respond for medical treatment. But it's typically within 1 to 2 days of onset of the DVT. So a thrombectomy is just a common surgical procedure for removing a clot. We have other less invasive surgical procedures that include balloon angioplasties, stent placement, and vena cava interruptions. So balloon angioplasties essentially just widen the vein after a blood clot's been dissolved. And then as the other balloon angioplasty procedures, it's similar because expanding that balloon in the vein causes the vein to widen and it improves blood flow. Stent insertion really can be utilized for DVT patients who have a vein that's prone to collapse. So, really, really poor vascular support and things like that. That stent expands once it's inserted and it just acts as a support for vein walls. And then the purpose of vena cava interruption is to prevent PE. So in this procedure, a provider surgically positions a filter, and you'll probably commonly hear it called that they had a filter place, an IVC filter place. But they place that filter inside the inferior, or sometimes not routinely, the superior vena cava. That's why it's called IVC filter, inferior vena cava filter. But sometimes they can place it in the superior vena cava, and it's between that DVT and the heart. So the blood flows normally through, it's like an umbrella-like filter, but the emboli get trapped, and that ensures that they don't reach the lungs. So the most serious life-threatening complication truly that can arise from a DVT is a PE, and it occurs in more than 1/3 of DVT patients. And then another complication that develops in 25 to 50% of patients after a DVT is post-thrombotic syndrome. So post-thrombotic syndrome is just a chronic disorder with clinical features that range from minor limb swelling and discomfort to severe leg pain, intractable edema, irreversible skin changes, and leg ulcerations. Clinical manifestations, like I said earlier, truly just kind of vary depending on the size, location, the degree of the occlusion, and how well someone has collateral circulation. But they may complain of that pain, the redness, swelling, and the warmth due to the obstruction. So for nursing diagnosis, we're going to include ineffective peripheral tissue perfusion, and that's going to be related to the interruption of venous blood flow. Acute pain, and that's going to be related to vascular inflammation and irritation, and edema formation. And then risk for impaired physical mobility is going to be related to pain and discomfort of the affected extremity. So, vital signs with oxygen sats, hypotension, tachycardia, and decreased oxygen saturations really could indicate the presence of PE. So that's why vital signs are so important with these assessments, is because if we just start seeing an automatic drop in someone's oxygen, they get super hypotensive and tachycardic, chances are if they've got a DVT and we know about it, we need to be assessing for a PE, because those are just kind of your classic vital sign symptoms. We also want to assess the extremity. So we assess the extremity for that pain, tenderness, warmth, redness, swelling, and common symptoms of the DVT that occur because of the obstruction of blood flow may indicate the location of the clot. So we also want to compare the left and the right extremity, or of the calf, of the thigh, of the arm circumference, wherever. If we can compare left to right, we need to. And this truly is just going to be looking for localized edema due to the obstruction to blood flow in one extremity, and that can suggest a DVT. Gentle palpation is used to inspect for induration or hardening, and that kind of helps to locate the placement of the clot in that blood vessel. And I know I mentioned it earlier, so D-dimer tests, when we're talking about lab tests, D-dimer tests measure the fibrin degradation products that are produced from a clot breakdown. So a positive result stratifies really the patient into a high risk category for DVT. We also look at those other things like I talked about, INRs, PTs, APTTs, sometimes anti-10As, things like that, just to see if it's prolonged or what kind of we're working with. We also want to look at hemoglobin and hematocrit, because this should be within normal limits. The PT-INR really evaluates the extrinsic coagulation cascade, and it's used to evaluate the effectiveness of warfarin. APTT evaluates the intrinsic coagulation cascade and is used really to evaluate, like I said earlier, the effectiveness of heparin. We also want to assess for signs of bleeding, such as bruising, petechiae, hematuria, bloody stools, because signs of bleeding can indicate a need to modify or decrease that anticoagulation therapy. So that's why monitoring our hemoglobin levels and hematocrit levels are also important, because we want to monitor for bleeding. It should be within normal limits. If we start seeing signs of bleeding and a drop in H&H, we probably need to notify, or not probably, we need to notify the doctor, because we probably need to start dropping or modifying their anticoag therapy. So, like I said, with nursing interventions or actions, like I said earlier, early ambulation. So, bed rest has been recommended in the past, but recent studies show that early ambulation does not result in more complications, and it's key to prevention. You're getting them up, you're getting them moving, you're getting that blood circulating. So they're getting up, they're not able to just pull blood and put them at a high risk for developing a clot. Another thing is leg elevation. So when we are at rest, the affected extremity should be elevated at least 10 to 20 degrees above the level of the heart to enhance venous return and reduce swelling. Compression stockings should be worn at all times. Compression promotes venous return and decreases leg swelling. Now, if someone has an active DVT, a lot of the times they don't want you to put that on their leg, but just for prevention and intervention, compression stockings, and you'll frequently see those legs elevated as well to help venous return and prevention. We also want to avoid, like I said, the use of SCDs, kind of with compression stockings, is the same for SCDs in an affected extremity. So an SCD really can cause the thrombus to break away, and that's going to result in an embolus. Encourage adequate fluid intake. It just prevents dehydration and sluggish blood flow, and that can exacerbate DVT growth. And then administer your meds as ordered. So your anticoag therapies, thrombolytic agents, things like that are ordered. Make sure that you're just administering those as ordered. For teaching, prevention of the recurrence is really the key here. So activities such as early ambulation and active leg exercises are really important. And then we want to monitor for adequate fluid intake, avoid constrictive clothing. We want to avoid for sitting with our knees bent or crossed for long periods of time, standing for long periods. Remind patients who are traveling on like long car or plane rides that can increase the risk of DVT, so they should stay well hydrated and move around whenever they can, or just do some leg exercises while sitting. Anything really helps. Encouraging patients to engage in activity that decreases the incidence of DVT by maintaining adequate blood flow through the extremity and avoiding activities or actions that constrict or limit blood flow is what we should also include. So we also want to make sure that we're educating on compression socks, on early ambulation, if they're on subcutaneous heparin, lifestyle changes, weight loss, smoking cessation. I haven't really hit on smoking, but smoking really increases your risk for DVTs. If we think about the plaque and in your body that it can build up from smoking, it puts you at a risk for clots and things like that. And then regular exercise really just helps to keep you healthy and keep your body moving. So evaluating care outcomes, when we are with these patients, we're going to be monitoring and evaluating if they're maintaining an active lifestyle and if they're maintaining compliance with treatment. And that is it. So this one was a lot shorter, but I figured it'd be easier to do it by itself. So anyway, if you have any questions, just let me know. Thanks.